So the next category is infection, and this includes Brody's abscess. So something like this, you see a lesion here within the shaft of the ulna. You also see a small lucency within the center of this. Now, this could be mistaken for an osteoid osteoma, and you would also want to keep that in the differential. But in this case, this was related to Brody's abscess, and so that's a little pocket of the nidus that's been walled off, the infection that's been walled off by the body. Now, compare this to this patient, which also has this abnormal area of cortical thickening. This could be infection as well. But in this case, and this could very well look like infection. So Brody's abscess and osteoasteomas can look very, very similar, and it can be very hard to distinguish from each other. But you do want to keep that in differential, that it may not be a tumor, but it may also be infection. In this case, this was an osteoid osteoma. This was infection. So Brody's abscess, the imaging really depends on the clinical stage. Acutely, you get aggressive periostitis, cortical destruction, and nausoscalp. You can see adjacent soft tissue findings like swelling and gas in the soft tissue. Subacutely, you're usually going to get these multilobulated lucent lesions with surrounding sclerosis, and you may see a sinus tract that goes from the center to the outside, and that can be helpful in distinguishing a Brody's abscess from an osteoid osteoma. So here's another example here of infection here. You can see that there's some cortical thickening in the regular distal femur. The radiographs usually suggest something, but the MR are usually going to be a lot more obvious. And in this case, you see this pocket of what ended up being an intraosseous abscess. When we aspirated this, we were able to get pus out, and there was surrounding edema here within the distal femur. So this is infection. Don't want to call this tumor, but this may be hard to distinguish from other entities. So it may require biopsy.